Can you see this?
Yep.
All right. I was set up to do this with the slide projector. And so we're going to talk about anticoagulation therapy. Why is it important? Number one, for the prevention of ischemic stroke. Patients with AFib have 5 times the higher risk of stroke or CVA compared to those with normal sinus rhythm. Atrial fib is the most common arrhythmia requiring hospitalization. Prevalence of atrial fib in the long-term care ranges from 14 to 17% of your patients. That's about 1 out of every 6 has AFib. VT is the 3rd most common cause of death after MIs and CVAs. So we don't have 1/6 of our patients on Coumadin or something to really deal with AFib as well as we should. That's just awareness. We don't prescribe, but doctors should be a little bit more aware of it. Right. The number one drug we think of is warfarin or Coumadin. The indications that the FDA approves warfarin for are prophylaxis and treatments of venous thrombosis, pulmonary embolism, prophylaxis and treatment of thromboembolic complications associated with atrial fib, cardiac valve replacement, and reduction in the risk of death for recurrent myocardial infarction and thrombolytic events such as CVA or systemic embolism after myocardial infarction. It's a very effective drug. It covers the whole range of most of the things we deal with those potential clotting problems, let's say. Warfarin is able to reduce the risk of CVA by 60 to 70% if maintained in therapeutic range of an INR of 2.0 to 3.0. Only about 50% of the patients that need some type of anticoagulation receive it. And the other scary part is, only of the patients receiving warfarin, they're in the therapeutic range of 2 to 3, only about 65% of the time. If they're at 1.8, and let me step back and say that, when we say 2 to 3, that's what's recommended, and that's a normal range for probably 80% of the population that require it. Every lab has a normal range. We've seen people fall out of that range as still being very normal. But with Coumadin, when you're dropping to 1.8, in most cases, you're not protecting them. They've dropped out of the protective range. And when you're running up over, additional interacting agents can cause rapid and exponential, not just linear, but very dramatic increases in INR, and thus increase the bleeding risk. Long-term care residents are already at an increased bleeding risk, and we should be that much more vigilant. Let me explain what happens there. You've got a patient that's been stable on warfarin, and warfarin's highly protein bound. They get an infection, UTI let's say, and the first thing you realize is if it's not a behavior is an elevated temp. And an elevated temp is usually caused by sloughing of protein. When you have a highly bound product and you're sloughing protein, what happens is you're adding, say this is a person's body, and you've got them in there along with protein-bound warfarin. And you're adding more warfarin on a daily basis by giving them a normal dose. When you're getting protein sloughed off into the bloodstream, plus what you're adding, in essence, we've increased the dose, or increased the amount of warfarin available in the bloodstream. So their INR is going to go up. And then we're going to add Bactrim. Bactrim competitively competes at the site where warfarin is bound. So you get even more warfarin out in the bloodstream than normally expected. So you almost doubled up on the amount of warfarin, let's say. So what's going to happen to your INR? It's going to go straight up. And then the antibiotic becomes effective, so the person stops sloughing protein, and you only have part of this bound by the body, but you're still giving the sulfa, and it's still happy. Then you stop the sulfa, and you've got another step. So we've talked about 4 different steps where the INR should change. We can expect the INR to change, maintaining the same dose. Now what happens if we react to seeing the INR change and reduce the dose? By the time we're done, they can be subtherapeutic again. Okay? What should happen, in theory, is when you see the infection, probably reduce the dose of warfarin, suggestive doctor, or especially when he adds an antibiotic. Would you like to reduce the dose of warfarin while they're on Bactrim and hold it for those 10 days, or not hold it, but cut it back, say from 5 to 4 to 3. And no, but if you understand what's going to happen, it'd make it that much easier. A little bit more confusing is the fact that oftentimes your INRs are showing what's happening 72 hours ago because of dose adjustments and the way it's absorbed. So this is why warfarin combinations cause more drug interactions than almost anything else. Than anything else. Like I say that, I'll show you that in another slide. And also cause us more problems. It's one of the most difficult drugs there is to manage. I would say that and dilating together are the 2 most difficult. But then these new drugs that I'm going to talk about, I'll show you some complications along with that. So what should you do when you start one of these antibiotics? Contact prescriber regarding the increased INR and the monitoring. And particularly, it's not a bad idea to go from twice a week monitoring to every other day. Not to change it, but to follow the trend. Because if we understand what's happening, we can make a better decision. So we want to pick up on the trend of what's happening and not just keep jumping up and down and react to what's happening, but plan ahead of it. So monitor closely, not just by labs, but you can almost expect, if you don't lower the dose, you're going to get some bleeding. You're going to get some additional bruising or something like that. So look for that and be aware to support the physician. And again, report any bleeding or bruising. Coumadin is a vitamin K antagonist. VKAs is another way to refer to them. So there's multiple, and the problems with them are multiple drug interactions, multiple dietary restrictions, unpredictable dose response characteristics because of the protein binding and some enzyme functions. It's confusing for the experts even. Frequent blood monitoring is required, multiple dose adjustments, which increases opportunities for errors. You have 3 different doses of warfarin in your cart sometimes for the same patient. So it's important to be careful. Patients don't like warfarin. They bruise. They don't like to see those bruises on their arms and legs. Very narrow therapeutic window, as we said. And the statistic is only 55% of the time are patients within therapeutic range. We don't do a good job managing it. List of some of the drug interactions. Now, I've got a handout with a lot more of them that we'll go back over when I get through the slide presentation. But it's food, not just drugs, that we ran through. Because it's all the NSAIDs, ibuprofens, all the penicillins. But a lot of foods we certainly know about: spinach and broccoli. How about black licorice or cranberries? So drug-drug interactions, worry about enzyme interactions, the other anticoagulants. The top 5 drug interactions identified in long-term care settings in the past year were warfarin and sulfa, warfarin and quinolones, which is your Ciprose, warfarin and macrolides like erythromycin, warfarin and NSAIDs, which is your ibuprofen and things like that, and warfarin and Dilantin. Those are, nationally, those are the top 5 drug interactions. Not just of warfarin, but of all drugs. So it gives you an idea of how it is. Now, in the past 6 months or so, there's been 2 new drugs come on the market to, quote, take the place of warfarin, heparin, and Lovenox, in theory. Reason for it is a great market for it. So many people are on it. Drug manufacturers have tried to come up with something to replace warfarin for 40 years. And there was one available coming out, was in final stages about 2 years ago, and probably 3 months before it was released, FDA rescinded it because of too many side effects. These also have side effects. There's also about 5 or 6 other meds scheduled to come out or planning to come out in the next year, all not in the same family, but all to aid in anticoagulation. And they're all different to some extent. So I thought I'd only talk about the 2 that were available, but give you an idea of what's going on with the other ones. One's dabigatran, the other is rivaroxaban. One targets thrombin, the other targets factor XA, and I'll show you a diagram in a minute to explain what I mean by that. Diabigan, which is Pradaxa, is twice a day, and rivaroxaban, which is Zeroxaline, I'll pronounce it correctly in a minute, is a once-a-day dose.
Yeah, just had Dr. P prescribe that for.
Yeah, we've had both of them in here, and that's why I'm doing this in-service. I felt that you guys were unprepared, and although I don't feel I'm very terribly knowledgeable on this, I learned a lot putting this together, but I thought it was important for you to get an idea of what we're working with here. All right, coagulation cascade, how coagulation occurs. There's a intrinsic and extrinsic methodology of what happens, and all these factors or proteins come together, and there's 2 pathways, the extrinsic and intrinsic. They basically come together at factor 10A, and that's where one of these drugs works, and the other one works way down here, which is the same place where Coumadin and heparin work. It's more important to start up higher. And I don't know if you can see this one at all, but at factor XA, Xarelto, or starts here, and Pradaxa down here, heparin's down here. Warfarin, for the most part, is down here. Does a little bit up here and a little bit here. Lovenox is primarily about here. So we want to be at factor 10A level, and that where the 2 pathways come together and then form thrombin, which in turn you get your fibrinogen and your clots, which are your problems that we don't want. And heparin and Coumadin work right here, as does Pradaxa. And Xarelto works up here. Dabigatran or Pradaxa, this is the FDA indication to reduce the risk of stroke in patients with non-valvular atrial fib. That's the only indication for it. If it's used for something else, we should not be using it here in the building. Now, it's all on this handout. You've got a copy of all the slides on the handout. Pradaxa works. And Xarelto. No INRs are needed or can be done, or because where it works and how it works, INR doesn't mean anything. And because it doesn't involve vitamin K inhibition, vitamin K won't work either as an antidote. So we do not have an antidote for it. Just says we don't have one for enoxaparin, for
Well,
Lovenox.
what's the half-life on that?
We can go back up and look at it. Half-life of Pradaxa,
12 to 17.
I'm sorry, 12 to 17 hours. And for Xarelto, it's 11 to 13. So they haven't come up with one. They're working on a couple of things. Even whole blood is what they're using. Still isn't terribly effective. They've been out a relatively short time. There's 50 attributed deaths to them already. They both have at least one black box warning concerned with the problem. They've also proven to be more effective than Coumadin when used properly. Lower incidence of breakthrough bleeding for the most part, or bleeding, and incidence of CVAs, or thrombolytic events. But again, we'll go on to the problems. No reversal agent is currently available. It's dabigatran or Pradaxa. It's 80% renally excreted. It is dialyzable, whereas Xarelto is not. And it's absolutely necessary when you start a patient, or hopefully before we start a patient, on either of these two new drugs, we do a creatinine clearance. And from there, take a GFR and follow these guidelines. Now, a patient is getting 150 milligrams for a normal patient, and for creatinine clearance below 15 to 30, we're going to half that dose. And anything below 15, we should not be using it. It's absolutely dangerous. If you've seen Pradaxa, it should have come in the original manufacturer's bottle. It's one of the very few drugs we cannot
It's
repackage.
its own little,
Okay.
it's not even in a bottle, it's in a blister pack, so it's not an
Blister pack.
individual
Okay.
pack.
I didn't even realize it. It came in its own blister packs. Okay. So if you're sending a patient home with it, make sure they don't take it out and put it in a pill vial or something like
Right.
that. It has to stay there. And sometimes it's dispensed, it's particularly in retail, in more than one bottle. Once it's open, 4 months is the shelf life for it. And again, the monitoring, monitor for bleeding, same time every day, 12 hours between doses, not BID but Q12. Missed dose within 6 hours. That shouldn't happen here. Again, original container and not longer than 4 months. Discontinuing the drug, whether it's for elevated active bleeding or an invasive procedure or surgery, you increase the risk of stroke. So truly minimize lapses. Remind the physicians of this, that this is the manufacturer's recommendation. Everything I'm saying here has come from either the FDA or manufacturers' things. Everything is printed. What I'm saying sometimes might be a little different. All right, let's talk about Xarelto, and I think we've seen that a couple more times.
I just got an order, just find out.
Okay. It has two indications. the risk of stroke for systemic embolism in patients with non-valvular atrial fib, which is pretty much the same thing as Pradaxa. But it also has the indication for DVTs following knee and hip surgery, and we'll see it a lot more often because of that. It works at that higher level, at that factor 10 level, and it's a once-a-day dosing. It prolongs pro time compared with normal conventional testing, and the only way to test it is the factor 10 chromatic assay, which is probably very expensive, and I don't think we're going to be doing that. Treatment requires no INR monitoring, and there's no current available antidote. So if you get a patient, you start on it, and they happen to be 95 years old, which means they probably have a pretty low creatinine clearance, even if they're healthy, you're going to get in trouble real fast. So you've got to get that creatinine clearance. Oftentimes they're coming from the hospital, and you don't know what it is. I'd get the doctor to order it on admission and get it as quick as you can, so at least you can alert him of the potential of the problem.
Right, because you have no monitoring when you're using these two drugs.
That's right. You have no you have no
Right.
lab monitoring. You have clinical monitoring.
You have visual assessments.
I mean,
and
visual
bleed,
assessments,
bleed,
and
bleed.
the first day or two till you get that lab back, I would do body checks. Pretty good. Look for problems. And again, if you discontinue it, you have an increased chance of some type of event occurring. It's eliminated both renally and biliary routes. Requires adjustments again for creatinine clearances that are low. All right. The advantages of these two new meds versus warfarin: no INR monitoring required, no food interactions, very little anyway. Lower potential for drug-drug interactions. There's not as many. More effective than warfarin in patients with poor control of INR. And lower risk of intracranial hemorrhages, both of those with Pradaxa. The disadvantages, it's much more expensive. I don't have current prices, but from what I've seen, a month's worth of warfarin is about $15. A month worth of these are over $200. Okay, so
But that's just for the pill. That's not including the monitoring that goes along with the treatment.
right, but I don't think INR's labs are very expensive. Do you have a price on it?
INRs are pretty reasonable, and we do our own strips, so.
Right. But
Yeah.
somebody at home, I was thinking.
It's still not very expensive.
Yeah.
So it's more expensive, lack of data with severe renal impairment, more GI bleeding with diabetic or Pradaxa. There's no antidote currently. It hasn't been used enough in the geriatric population, because when they test drugs, very seldom do they use geriatrics. They don't go after people over 50 in most cases, because they have too many other disease states at the same time. They don't feel they get a clear indication. So when we get a new drug, any drug that's been on the market less than a year, I'm very slow to start using it, because how many times in the past couple of years have we had things like Celebrex get restrictions, and the other two that were like that were taken right off the market. I'd like to watch and go slow if we have an alternative. But renal function is imperative, and I can't stress that enough. If you don't get your creatinine clearances right away, you're not being fair to the patient, the home, anyone. In summary, after decades of limited options, we have two new things available, and in the next 6 months we'll probably have 3 or 4. A couple of them look like they might be better, but till we see the information, we'll just have to wait. The new ones, no required INRs, fixed dosing, fewer interactions when compared to warfarin. And if you compare it to Lovenox, they have a little bit better profile of effectiveness, and they're oral medications as opposed to injectable. And they're probably a little bit cheaper than Lovenox, unless you have to give either these meds twice a day. If they're given once a day, they're generally a little bit cheaper than Lovenox. The risk of major bleeding is really unknown. Compliance with these new agents are important due to their shorter half-lives, because warfarin has about a 30-hour half-life. Patients with excellent INR control have little to gain by switching. And if the docs and you guys do your job, you should have excellent control. That's a big if, though. I mean, how many patients do you see sitting at a 1.6 or 1.8, the doctor's not changing the dose? And when you're monitoring, or you see labs come through, look at the trend. Where's it going? Assuming that the patient's stable, their diet's normal, everything else is normal, they're not having a fever. If it's not bouncing around, they're not. I would not suggest them being a candidate for newer drugs. If they bounce around all the time with no changes, maybe it's a potential thing. It's not always great to jump on the new things. So that's it for the slide presentation. I do have a handout. I'll cover a couple other things. Okay, first one is a care plan that might, this is Omnicare's suggested care plan for Pradaxa or dabigatran. I'm not going to go through it. It's probably not consistent, terribly consistent with what LifeCare's is, but it's close enough that it may be a supportive thing, and I'll leave it with you, Jan, to see if you want to incorporate anything with it. The next one's for Xarelto, and then if we go on to the next page, dosing and drug interaction considerations. Can you switch over to, well, unless you have questions.
No.
Okay. Dosing and drug interactions for dabigatran and rivaroxaban. Just so you're aware of them, I'm not going to go through them. Again, a quick thing on creatinine clearances, so you can possibly keep these on your MAR, or keep them at the nurse's station so that you can refer to it and know what's normal, what you should be doing. Drug interactions is the following page. I'm just running through it quickly. If you have questions, you can ask me. I lost the last page. Well, my last page is and I'll find it for you. Here it is. Antibiotics and anti-infectives that interact with warfarin. And I'll give you this page also. And it's a more extensive list than you see than with the other drugs.
Right.
So these are all interesting. I didn't spend much time on heparin or Lovenox. And Lovenox, as you know, is low molecular weight heparin. Lovenox works a bit better, less side effects, much more expensive. Heparin, again, works about the same as Coumadin.
And how can patients are on heparin as opposed to Coumadin?
But you have to ask the doctors.
Okay.
Any questions? Okay. Also was asked to talk about narcotics. Want me to cover that as well, Jan? Or just two people?
When are we coming back next week? Was that over anti-anxiety and stuff?
Next month.
Let's do some narcotics now.
Okay. It's going to be right here. Okay. Talking about narcotics or controlled substances is probably a better not just narcotics that we deal with, that the DEA is concerned with. All class 2, which is the most restrictive medications, and the DEA, which is part of Justice Department, looks at these as potential for abuse, not by drug classification or therapeutic area particularly. And what's in class 2 is pretty much the single narcotics, the amphetamines, some other stimulants, some of the testosterones in there, some of the muscle products, anabolic steroids. Class 3 and 4 is the barbiturates, all the sleepers, all the benzodiazepines, so we're talking about Ativan, lorazepam, Klonopin. At this point, all of those need a written prescription in order to be filled at the pharmacy. Now that can be faxed to the pharmacy, but it has to have the doctor's signature on it. And none of you can act as his agent and provide him with a script. He has to sign it the day that he issues it, and he has to write it out. He or you can fax it to the pharmacy, and there we can do partial refills on them, as you know. Taking things out of the emergency bucket or taking things out of the Pyxis. I'm talking controlled substances again. You can't, even if you have an order for it, you cannot take it out without contacting the pharmacy and having a pharmacist authorize you to take it out of the Pyxis. The DEA looks at that as a different dispensing pattern than getting it from the pharmacy. It's silly, but we're dealing with what the law is. It's just not fair to the patient, but that's the law, and we've got to go with the law. It's a zero tolerance thing. I can tell you that Omnicare, not in Phoenix, but in other parts of the country, and Omnicare is in 47 states, has paid well over $100,000 in fines because of things like that. They have zero tolerance. Your company has zero tolerance, as you're aware of. So that's the guidelines. All right. One other point I want to talk about is pre-ordering medications. If you use OmniView rather than calling into the pharmacy, what happens is if you pull the stickers off and just scan them through OmniView, it goes directly into the Omnicare computer in Chandler. Nobody touches it, no one touches it. It gets put in order, and it is the fastest way to get a medication back to you. If you call it in, you sit on the phone and wait a few minutes. We're better now with our new phone system, but you sit on the phone, you wait till someone picks up, takes it, and puts the order through. The other thing is, if you fax it, it's going to sit there in a pile. So someone says, oh, I got to pull LifeCare's folder out, enter it in the computer. Could be 3 hours.
We talked about this at our last meeting.
Okay.
Either other way, you're involving a second party, so
At least the second part.
do the computer
Through the
scan.
computer. And the other thing, once you put it in, once it's in the computer, whoever puts it in, whether you put it in or a pharmacy tech puts it in, you can go into OmniView and see the status of it, where it is in the filling process or delivery process. You can check all that. I'm not sure, but I think you can also see if it's been delivered, who signed, if it's been delivered. You should be able to do that.
There's a delivery date. We can't check who signed for
You
it.
can't check who signed for it,
Call, yeah.
but you can see if it's been delivered.
I think you can check who signed for it.
Can you?
Yeah.
I'm not sure.
Computer?
I don't work with it enough, but it's so much easier and so much faster for you.
Yeah.
It's just a scan.
Right.
Technology is getting there. I'll tell you about one more thing that's coming. within probably a year, physicians will be able to use their cell phones, their smartphones, and order prescriptions, including controlled substances, on their phones directly into the pharmacy. No signatures. You know, there'll be a whole certification process for each physician. The FDA has approved it federally. It's not been approved by every state, so it's going to take some time. But it should make, it's better for the patient, number one.
Yes.
It'll save you and I being the middleman.